Hi again to those of you who are joining us live, and for those of you who are joining us by recording. I just want to take another minute to thank everyone for their interest. My name is Jan Bogie. I'm a licensed mental health counselor, and I work here at Healthy Mothers, Healthy Babies. I'm the clinical director. So one of my roles here is to plan and facilitate our CEU events. This is actually our third one this year, I guess, if you will, and we're really excited to have Faythe presenting today, and I'll be introducing her here in just a couple of minutes. So for those of you who aren't familiar with our agency, Healthy Mothers, Healthy Babies, what we do here is we provide services to improve birth outcomes and promote healthy families. We provide access to care, education, support to those facing challenges, especially those of pregnancy and of infant care. So we screen women for physical and mental health, either in the Healthy Beginnings system or in the community, and link them to services within our system or in the community. We also have screenings specifically for mental health. We have some mental health programs as well. Those are called Circle of Moms and our Share Pregnancy and Infant Loss groups. So those are support groups. Right now we're running them almost every day, and that's mostly because of the COVID changes. We also have a pantry that's operating and open right now, and we're providing formula, diapers, and infant food packs. So if you have any moms who have those needs, please have them stop by during our pantry hours, or just give us a call and we can provide more information. And for those of you who are looking for more information, our website has all of that available as well. We have several programs here. I'm going to talk a little bit about what Faythe does here, which is she's one of our community liaisons. So she works really closely with the OBs in the county. She gives them lots of education, specifically about the Florida Healthy Start prenatal risk screen. And she just works with them in general on maternal health topics. And so we're really excited to have her here today. And I'm going to go ahead and introduce our presenter today, Faythe. So Faythe Edmunds is a nationally certified health education specialist. She earned her bachelor's degree in sociology at Spelman College and her master's of public health at Emory University. At the Rollins School of Public Health, she studied behavioral science and health education and was trained in the cohort of the Center of Excellence in Maternal and Child Health program. Faythe specializes in Black maternal and infant health disparities and has conducted mixed method research pertaining to racism and toxic stress, experiences of discrimination in healthcare, breastfeeding practices, stigma, and environmental exposures during pregnancy. In addition to her research background, she has extensive experience working with nonprofit agencies on program evaluation and community assessment needs. At Emory University, she held positions collaborating with both the School of Medicine's Department of Pediatrics Health Equity Team and the School of Nursing to reach some of the most marginalized subgroups of women and children in the metro Atlanta area and identify challenges in their system of care across the life course. Faythe was selected to participate in the Women of Excellence Leadership Series in 2016 and recognized as a graduating Woman of Excellence in 2018, and is currently a member of the Jewish Women's Foundation's Young Leaders Society for her commitment to social justice and future global impact. Faythe currently serves as a community liaison at Healthy Mothers, Healthy Babies of Palm Beach County, and we love her here. And she also left out of her bio that she's also been on our employee spotlight before. So without further ado, Faythe, I'm going to hand it over to you.
Thank you, Jan, for that introduction, and good morning to everyone. Thank you for being here today for this presentation, Learning from Tragedy, Maternal Morbidity and Mortality. I wanted to start with a moment of acknowledgement. The photos here are some of those identified with the ProPublica series, Lost Mothers. At HMHB, our thoughts are with all of their loved ones and the loved ones of those women who did not make the headlines. It is in their honor that we work together to address this challenge. So to give you an idea, here's an overview of the subjects we're going to cover this morning. This is a massive issue, so please know that I've done my very best to consolidate the main things that you need to know during our time together. My hope is that this experience will be as interactive as possible. So periodically, I'll be asking you for your thoughts, as I believe that we can all learn from each other. At those times, we would love to hear from you in the chat. First, we're going to examine the data and where they come from. In doing so, we'll start broadly by considering the United States, and then we'll narrow our focus to Florida and even Palm Beach County. Next, we'll spend some time diving into the disparities that are present, most of which surround race. And to finish with a glimpse of hope, because that's important in this conversation, We'll talk about what is currently in place to address these challenges and what is recommended for moving forward. When we get to this portion in particular, I would really like for you all to position yourselves in a space where you're thinking about how this can apply to you in your role, both professionally and personally. So why should we care? Maternal death is a rare culminating event, meaning that it's the end result of a series of failures across the life course of a woman with respect to her health care. Not only does a maternal death impact the immediate social community of a woman, so friends, families, coworkers, but it spreads out to society at large, as a potential productive member is no longer able to contribute. This is an economic consideration that we call the ripple effect, which is often overlooked. When compared to other developed nations, the US ranks significantly higher in terms of maternal mortality rates. For example, the UK, Canada, and Sweden. I do want to acknowledge that there is a lot of discussion around the validity of these numbers due to issues with tracking deaths in different ways. Nonetheless, what we do know is that even with advancements in technology, our rates are increasing while our counterparts are decreasing. Unfortunately, we continue to learn that far too many of maternal deaths that occur in our country could have been prevented. While maternal health behaviors, lifestyle, and genetic factors do play roles in adverse outcomes, the conversation does not end there, and must include the impact of psychosocial influences. When we dive into the contributing mechanisms that researchers have uncovered, we will see that social determinants of health make up a vast majority of the risk factors. These are things like food insecurity, lack of access to safe housing, low health literacy that can and often do begin long before conception and make a pregnancy that much more challenging. These circumstances are not evenly distributed and call for work to achieve equity. Maternal health epidemiology includes several key terms that I want to make sure we all understand. Those that I'm going to be using are here for us to review. There can be a lot of confusion if you're not careful because the definitions tend to vary slightly, and that can be tricky to remember. What is critical for you to know is that while these terms are closely related, they are not interchangeable. So try your best to stay with me through this part. As the poll touched on, the primary difference between a maternal death and a pregnancy-related death is the time allotted. For a death to be considered maternal, it has to fall within 42 days, whereas being pregnancy-related opens up that window to within 1 year after the end of a pregnancy. The other important note about these two definitions is that they do not include accidental or incidental causes, such as car accidents or falls, where women were pregnant, but the deaths were not caused by the pregnancies themselves. As I mentioned, maternal deaths are still very rare. What is much more prevalent is maternal morbidity. The reason why it is so important that we pay particular attention to morbidities is because they are the precursor to maternal death. While these experiences are not ultimately fatal, the impacts can be lifelong. In a general sense, maternal morbidity is defined as the physical and psychological conditions that result from or are aggravated by pregnancy and have an adverse effect on a woman's health. But that is very broad. So what exactly does it mean? Well, there are two main categories that break the concept down further. Severe maternal morbidities include the unexpected outcomes of labor and delivery with significant short or long-term consequences. These morbidities have a life-threatening diagnosis or a life-saving procedure required during delivery hospitalization. Severe acute maternal morbidities are those that we refer to as the maternal near-miss group. These are the women who nearly died due to a complication that occurred during pregnancy, childbirth, or within 42 days of a termination, but they survived solely because of an intervention. Now we're going to get a little bit more specific in the causes of death that are categorized as maternal or pregnancy related. We have what we call indirect and direct causes of death, and you will hear references to both as we move forward. Indirect causes are those that we see become aggravated by the physiological effects of a pregnancy. Some of the most common pre-existing diseases and examples of those conditions are listed here. For anyone who may be wondering what cardiomyopathy is, it's an acquired or hereditary disease of the heart muscle that makes it difficult for the heart to deliver blood to the rest of the body. The most extreme outcome is typically heart failure. Traditional causes are what you most likely consider first for maternal mortality. These are conditions that result from obstetric complications and include things like infection, respiratory complications, or hemorrhage, which is a rapid loss of blood. Do you remember how I mentioned that there has been a lot of inconsistencies surrounding how maternal deaths are reported? I think it's important that to spend a little bit of time discussing the history of our surveillance techniques so that we can understand why this issue has recently garnered so much attention. Now, death certificates have always been the primary source for tracking maternal mortality. However, it was not until 2017 that all states and US territories finally standardized a pregnancy checkbox on the form. Prior to that, with vital registration systems being controlled individually by each state, the implementation was slowly included dependent on what state laws, technology, and funding allowed. To really illustrate the lag here, I want to make clear that the National Center for Health Statistics first recommended this inclusion of a standardized pregnancy checkbox back in 2003. This caused many challenges with both underreporting and overreporting of the real trend, so much that the NCHS officially suspended publishing national mortality data in 2007. That was a monumental indication of a lack of confidence in our system. As a result of this, the American College of Obstetricians and Gynecologists, the Centers for Disease Control, and state health departments collaborated to form the Maternal Mortality Study Group. This group is responsible for the gradual uptake in electronic record keeping, devising the standardized pregnancy checkbox option on death certificates, and expanding the WHO's International Classification of Diseases definition for maternal death. In 1986, the CDC first began national surveillance of pregnancy-related deaths through the Pregnancy Mortality Surveillance System. Each year, 52 reporting areas, including all 50 states, voluntarily send copies of their death certificates for all women who died during or within within 1 year of pregnancy, linked live birth or fetal death certificate, and any additional data that may have been available. From here, all of the information is analyzed by medically trained epidemiologists who determine the time and cause of death related to the pregnancy. The alarming statistics that you have heard surrounding maternal mortality have been made possible to access because of this group's efforts. A very problematic trend has surfaced over the past few decades. We now know that those underlying health conditions that we discussed as indirect causes of maternal death are becoming increasingly prominent. What I want you all to consider is how this relates back to social determinants of health over the life course of women. I'm sure we have all heard of the silent killer, hypertension. For women who lack access to healthcare or maybe are consumed by a work life that doesn't allow them the time to make doctor's visits to monitor their preconception health, that is a serious condition that left undiagnosed or untreated will absolutely worsen during a pregnancy. These are the types of things that we need to be keeping in mind. Now that we've covered the basics, we're going to get into our detailed discussion on maternal morbidity. I would like to start with the short video that covers a few stories of the near miss group that we touched on. Full disclosure, these descriptions are graphic. This will be a time to take some deep breaths if you need to. If there are any initial reactions, comments, or thoughts to share amongst the group, please feel free to do so in the chat. National occurrences of severe maternal morbidity, or SMM, are analyzed by the CDC. The organization uses hospital discharge data and the list of ICD-9 and ICD-10 codes to track the occurrences of 21 indicators. The original list included 25 items, but as of 2015, it was revised to be 21. On the right here, you can see the most common indicators that are reported, with necessary blood transfusions being the most prevalent, followed by hysterectomy and the usage of ventilation. What is important to know is that there is currently no ongoing system of data collection for maternal morbidity, and it is unclear how often these analyses take place. When they do, each record found is weighted using a complex sampling design that is set to represent the population. And this is how we are able to determine that morbidity is between 50 to 100 times more common than a maternal death. Keep in mind, these data only account for hospital births and those that are only severe. What are some other gaps that you can think of? Are we missing those that are still traumatic birth experiences, but were not life-threatening? And what about those that occurred after a mom was discharged? Based on recent estimates, it is believed that on average, 50,000 women per year suffer from a severe maternal morbidity experience. This number is low, as we have seen ranges including as high as 80,000 women projected in reports over the past few years. This goes to show the inconsistency in determining the true severity of the problem and the theme of underestimating and overestimating. I chose to highlight this quote from an NPR story in particular because it encompasses what I think are so many of the overlooked challenges that come about due to these unfortunate scenarios, and they're not discussed enough, namely the financial burden of high medical costs associated with complications. How often do we create safe spaces for women to disclose their fears of pregnancy because of a birth trauma? Do we even consider how many are suffering in silence? Are serious complications becoming so common in our country that they are just expected as part of the labor and delivery process? As a standard, the maternal and child health status of a country is regarded as painting a picture of the overall indication of success or lack thereof of the national healthcare system. So what is causing such a decrease in the quality of our maternal health? The consensus amongst the research community is that these 5 factors play a significant role. Do any of these surprise you? This list is by no means exhaustive, but they are some of the recurring linkages that lead to a higher risk status for women across the board. So what do I mean by unnecessary C-section? And why is that at the top of the list? It is no secret that C-section rates have skyrocketed over the past few decades, and there are some reasons as to why, but for the purposes of this discussion, we're going to focus on the associated risk. With this major surgery, women may become more susceptible to excessive blood loss, infection, blood clots, and higher chances of complications in future pregnancies. If you recall, there is a lot of overlap between the potential consequences of C-section and the morbidity indicators and causes of death that we've examined so far. And statistically, the risks are higher than those present in vaginal delivery. Now we're going to start narrowing our data analysis to zoom in on Florida. This table here summarizes 4 years of the rate of frequency for the top 5 severe maternal morbidity indicators from 2 ICD code lists. Between the 2 lists, you can see that the highest rate per 10,000 deliveries is by far blood transfusion, most closely followed by heart failure during procedure or surgery. Remember that blood transfusions are the most common occurrence on a national level as well. I would also like to point out that 2 out of 5 conditions on both lists are directly related to the heart. Heart disease is the leading cause of death for women in the US, and is also often described as one of the silent killers. What does this tell us about how we should be prioritizing preconception health to minimize these occurrences of morbidity? Here we're going to learn about the maternal profile created by the results in the Florida Department of Health study. Like Jan mentioned, my role at HMHB is to ensure that every woman in Palm Beach County is offered a prenatal risk screen to determine her level of pregnancy risk. As a general rule of thumb, a score of 6 or above is considered high risk, although there are particular circumstances that are automatically areas of caution and are flagged. For example, drinking or smoking, depression, or having a BMI greater than 35. Often this assessment is presented as a way to focus on the birth outcome and the health of the infant, so to minimize risk for preterm birth or low birth weight. But it's important that we don't leave mom out. In this study, the research team investigated an association between the mother's prenatal risk screen score and the occurrence of severe maternal morbidity. What they found is that women who scored 6 or more were likely to have a severe maternal morbidity experience, and that relationship was even stronger amongst those who scored 10 or more. I've included these graphs so that we can take a deeper look at some of the predominant characteristics that increase a woman's risk in Florida. These rates illustrate some very stark differences. Do you see those high rates for those with either chronic or gestational hypertension and diabetes compared to those without? I'd also like you to look closely at the rates for different payer sources. Any thoughts on why Medicaid and Medicare recipients have the highest rates? We're going to get into that a little bit later. To provide a little more expansive version of Florida morbidity data, we're going to talk about findings from the most recent state PRAMS report. PRAMS is the Pregnancy Risk Assessment Monitoring System that is a random population-based surveillance measure for maternal health behaviors and experiences. The CDC and Florida Department of Health initiated PRAMS monitoring here in 1993. The first section dedicated to maternal morbidity gathered data on the following measures before pregnancy and a sample of approximately 1,000 new moms who completed the survey. From these measures, there are a few findings that I want to highlight. Overall, 15.1% of the sample had low iron during the 3 months prior to pregnancy, but that percentage increased to 30.8% for Black women, and 20.2% of those who reported this anemia were Medicaid recipients. For the depression item, overall 7% of the sample reported being diagnosed with depression before pregnancy. The highest prevalence in race was among white women with 8.9%. Those who were 35 and older accounted for 8.2% of the responses. 9.7% reported less than a high school education, and 11.3% reported a household income less than or equal to $15,000. Lastly, on the anxiety question, 12.5% overall reported having anxiety during the 3 months prior to their pregnancy. Again, the highest prevalence in race was among white women with 19%. Those 19 and under responded at 22.3%, and 16.6% for ages between 20 and 24 years. 15.7% of the positive responses for this item were Medicaid recipients, and 15% were not married. Listed here are the during pregnancy measures for maternal morbidity on the PRAMS survey. I'm going to go through a few of the profiles here as well. Overall, 12.7% of the sample population experienced hypertension during pregnancy. 20.5% of the positive responses on this item were Black women, and 23.1% were 19 years old or younger. 14.1% had a high school level education, 14% were Medicaid recipients, and 14.8% were not married. The prevalence of premature labor pains was 19.8% overall. 32.3% of the responses for this item represented those 19 years or younger, and 31.7% had less than a high school education. 28.1% had a household income of less than $15,000, and 26.6% were Medicaid recipients. There were some interesting findings with respect to gestational diabetes. Overall, 12.1% of the sample answered positively, with 13% representing Black women and 12.3% representing Hispanic women. 12.6% of the positive responses on this item were between ages of 20 and 24 years. 14.5% were not Medicaid recipients, and 13.1% were married. As promised, now we're going to take a look at the health status report of women in Palm Beach County and think about what this means for the mothers in our community. Listed here are the preconception health and behavior indicators that are ranked 1 through 4, with 1 being the most favorable and 4 being the least favorable rate. Some of the challenges that stood out to me most are that we are ranked a 3 for the number of females between 18 and 64 years who have health insurance. What consequences could this have? We are also ranked a 4 for births to mothers with a healthy weight, and a 3 for births to overweight mothers at the time pregnancy occurred. In this table, the indicators listed relate directly to pregnancy and mother's health behaviors, with the same ranking parameters. As you can see, there is a lot of room for improvement with prenatal care timing, attention to weight, and especially the number of C-sections taking place, where our county rate is slightly higher than that in the state overall. Now that we've covered morbidity as a precursor, we're going to transition into our analysis of maternal mortality. These are 2 of the most startling numbers that you may be familiar with. We know that about 700 women each year lose their lives in this country as a result of complications related to pregnancy or delivery. And we also know that 60% of those deaths did not have to happen. The NCHS has resumed publishing maternal mortality data and most recently made the 2018 rate of 17.4 deaths per 100,000 live births available to the public. On a national scale, here are the 6 most pressing challenges that have been named as contributing to maternal death. In discussing morbidity, we also saw most of these causes listed, aside from suicide and drug overdose. Considering trends with mental health and substance abuse disorders in this country as a whole, why do you think these might persist within the pregnant and postpartum subgroup? Here you can see the breakdown of pregnancy-related mortality ratios by race and ethnicity between 2011 and 2016. I do want to acknowledge that throughout this presentation, you will see the term American Indian due to the fact that this is the racial category used in government documentation. However, my personal preference is to say Native American whenever possible out of respect for the indigenous community. So you will hear varied identifications relating to this group. Both Black and American Indian Alaska Native women have significantly higher ratios than all other races, with 42.4 deaths and 30.4 deaths per 100,000 live births, respectively. Hispanic women have been reported as having the lowest pregnancy-related mortality ratio at 11.3 deaths per 100,000 live births, behind white women with 13 deaths and Asian or Pacific Islander women with 14.1 deaths. Do we have any ideas as to what may differentiate the Hispanic population from other minorities? There are a few theories that we will touch on soon. Again, we are going to assess maternal deaths close to home. On the left, this graph summarizes the leading causes of pregnancy-related death in the state between 2007 and 2016. Our data does align with much of what we found nationally. What is most striking is the increase in cardiovascular-related deaths between 2007 and 2016 and 2017 alone, soaring from 7.6% of deaths to 28.6%. Positive news to report can be illustrated in the decreases in deaths from hemorrhage and hypertensive disorder. We will be discussing some of the work that has likely contributed to those improvements. On the right-hand side are the counts of maternal deaths in Palm Beach County, compared to those in the state during the same year. For ease, I have circled the numbers that I would like you to pay special attention to. Between 2010 and 2018, there have been 34 reported maternal deaths reported in Palm Beach County, and 408 deaths across the state in that same time frame. The Florida Department of Health released a report documenting the findings from review of 35 pregnancy-related deaths in 2017. 48.6% of the women lost were Black women, 34.3% were white women, 14.3% were Hispanic women, and 2.9% were other races. 28.6% of the deaths were cardiovascular related. Hemorrhage, thrombotic embolism, and infection all accounted for 14.3% independently, and cardiomyopathy made up 8.6%. Particularly important to note is that 89.2% of these deaths occurred during the postpartum period, specifically with 46.9% prior to a hospital discharge and 37.5% after. Additionally, we know that 68.6% of the deaths occurred after a live birth, followed by roughly 17% during or after an emergency delivery, and 5.7% while still pregnant. 53.3% of the deaths reported were representative of women who had C-section deliveries, where 30% of those were planned and about 23% were not. And 53.8% were overweight or obese at the time of their death. We have already seen that between 2011 and 2016, Black women had the highest maternal mortality rate, and that is proven to be true again in the 2018 statistics. But what group is missing here? Native American women. Unfortunately, this is often the case with many reports on maternal morbidity and mortality due to racial misclassification and surveillance, or notions that they are not a large enough group to be statistically significant. With the exception of Puerto Rican women, Latinas, namely immigrants from Mexico and Central America, are said to have a few protective factors that may explain their having the lowest rates of maternal mortality. The prenatal paradox is a theory that attributes their positive maternal and birth outcomes to strong cultural support for mothers, a healthy traditional diet, and avoidance of risky behaviors such as drinking and smoking while pregnant. For minority women in this country, there are many shared experiences that impact both quality of life and relationship with the healthcare system. I have listed some of them here. By analyzing these themes, in this section of the presentation, we're going to put a lens on some of the experiences of Black, Native American, and Hispanic women living in the United States. To start our segue into this conversation, I'm going to play a video that details the historical remnants of racism and reproductive health for African American women in particular. I hope that was informative. Again, please feel free to share any initial reactions in the chat. Native American women have had a very similar experience when compared to that of Black women. Therefore, it should be no surprise that these mothers are also dying at disproportionate rates. The Native American population continues to fight through a history of colonization, genocide, forced migration, reproductive coercion and infant separation, cultural erasure, and social isolation. We must consider how this dark past influences Indigenous women and their pregnancy. Hispanic women have also lived through forced sterilizations, mass deportations, and an ongoing hostile culture directed towards Native Spanish speakers. While these lists are by no means exhaustive or completely generalizable to every woman's lived experience, acknowledging this history is helpful in providing insight for addressing challenges that arise and providing services to disadvantaged groups. The vast majority of research regarding systematic oppression and social determinants of maternal health has focused on the large Black-white disparity. We know that there are 5 main areas of social determinants where Blacks are disproportionately disadvantaged when compared to whites. You can see them listed here on the left. What I want to be sure I clarify is that biology and genetics does not mean that Black genes are inherently wrong or faulty, but more so that we have seen intergenerational trauma and its impact on the body passed down through generations. Wealth and income disparities as a result of structural racism in the US have also been indicated as an attributing cause to high rates of Black maternal mortality. Women of color are often very marginalized in terms of access to family planning services that would promote healthy maternal outcomes. Our most pressing concerns here are preventing unintended pregnancy and ensuring safe spacing, which is recommended as 18 months. Racially discriminatory policies have also been documented for decades as significantly hindering the Black population's livelihood. So what are some examples of this? It starts with residential segregation, which you may know as redlining. The ripple effect of this has designed low-resource communities, concentrations of unemployment, crime, homelessness, and limited access to adequate health care. And what is most troubling about all of that? We know that the hospitals located in those predominantly Black neighborhoods across the country are those with the poorest performances. So when you couple a population with many pre-existing conditions and poor performing medical staff during pregnancy, are any of us surprised to learn that Black women are dying at a rate 3 to 4 times higher than white women? We shouldn't be. In recent years, there has been more documentation focused on shining a light on this systematic oppression of the Native American community as well. When compared to white women, Native American women are more likely to live in poverty and hazardous conditions, be food insecure, lack access to health insurance and adequate health care, experience sexual and/or intimate partner violence, and have behavioral health challenges. While not all of the Indigenous population lives on secluded reservations, 40% do live in rural communities, more than any other racial group in the US. This often makes transportation a common barrier to accessing necessary care. I also want to point out that the Indian Health Service, which was created to provide culturally competent healthcare to this group, is one of the most notorious, historically underfunded federal programs in this country. Here we're going to talk about a concept that you may be familiar with, chronic stress and weathering. While race itself is a social construct, the physical effects of living through racism are not. Both Black and American Indian Alaskan Native women have been documented as reporting the highest number of stressful life events in the year before birth. Specifically, Black women have been 24% more likely to report emotional stressors, 35% more likely to report financial stressors, 163% more likely to report partner-related stressors, and 83% more likely to report traumatic stressors than white women. These stressors all begin to take a toll on the Black woman's body. The weathering effect was coined to describe the rapid deterioration of organs which manifests by entering into pregnancy with a higher susceptibility to disease onset and a diminished ability to respond to treatment. New research has found that it's likely this theory applies to Native American women as well. Race-related stress presents itself in three main forms: vicarious racism, collective racism, and the intergenerational effects of racial group trauma. This is what I was referring to with the disadvantage in terms of biology and genetics. These categories of racism influence the lives of women on a scale from daily lived experiences and microaggressions to the perceived experiences of the racial group as a whole throughout history. This figure on the right depicts a summary of many of the topics that we've discussed so far. You can see that disadvantaged environments serve as the foundation for a pathway to maternal mortality. So why do we need to talk about preconception health? Because damaging conditions that are left unaddressed and unmanaged before a woman conceives are likely to worsen during a pregnancy. Between 2008 and 2012, 17.3% of Black women reported having at least one pre-existing condition prior to pregnancy. Those included hypertension, obesity, diabetes, cardiovascular disease, asthma, and HIV. We also know that Native American women have been found to have the highest rates of 4 out of 5 preconception risk factors, which are at-risk drinking, smoking, diabetes, and mental distress. There is not much research published about preconception health within the Hispanic population. However, we do know that rates of diabetes are higher than that within the white population. Puerto Rican women in particular have been documented as the most at-risk subgroup in this population due to rates of poverty, diet, obesity, asthma, and in some cases, alcohol and drug use. Foreign-born Dominican and Mexican women have also been cited in studies based in New York City as having elevated rates of hypertension. There are a few very important maternal risk factors that we cannot leave out of this conversation. When we look at pregnancy-associated deaths, substance usage, severe mental illness, and intimate partner violence are 3 of the most significant predictors of this outcome. By definition, these are the deaths that occur while a woman is pregnant or within 1 year after the end of a pregnancy, regardless of the cause. So when you think about lost mothers, do you think about those who are lost due to drug overdose, suicide, or homicide? Do you think that pregnancy plays a role in those causes of death, or is it just a timing coincidence? Broadly, we know that advanced maternal age, no prenatal care, low education, and low socioeconomic status represent the most common risk factors for pregnancy-related mortality and severe morbidity. Prenatal care utilization and timing can serve as a risk or protective factor. All 3 minority groups that we have been discussing have been deemed as at risk for late entry into prenatal care. Why is that? Well, some of the barriers that have been documented from women include cost, transportation, insurance eligibility, and wait time. We also know that women with unintended pregnancies are more likely to seek late prenatal care. The highest risk group of these women are those that have 4 or less prenatal visits during their pregnancy. Native American women are 3 to 4 times more likely to begin prenatal care in their 3rd trimester than white women. Black and Hispanic women are nearly 4 and 2 times, respectively, more likely to receive between 0 and 5 prenatal visits when compared to white women. So is seeking early prenatal care enough? Well, maybe it would be if it were not for our healthcare system and experiences of discrimination for women of color. With perceived racial discrimination comes very serious consequences. We see not only poor communication between patients and their providers, but also lower levels of treatment adherence when it could matter the most. A common complaint is that discrimination occurs on the basis of payer type. So why does this matter? Because minority women are more likely to rely on public insurance, and many are not eligible for Medicaid prior to pregnancy. Race-related stress also presents itself in the form of internalized racism. How so? When women become discouraged and feel less empowered, they may be less likely to engage in a healthcare system that they perceive as too daunting. So how can they be reached and assisted if they have been led to avoid the system as much as possible? Research around this topic is well documented for all three of the groups we are discussing today. When compared to white women, Black or Hispanic race or ethnicity has been associated with 3 times higher odds of discrimination due to race, language, or culture. In addition to this, approximately 25% of Native American women report experiencing some form of discrimination when going to the doctor or a clinic. They are also more likely than white women to report delays in care and a different provider at each prenatal care visit. To reiterate our point outside of just the Black community, evidence continues to illustrate that racial and ethnic minority women deliver in lower quality hospitals than white women. So much that when minority women deliver in predominantly white serving hospitals, their risk of severe maternal morbidity is decreased significantly. I wanted to include this figure because I think it does a wonderful job of visually summarizing just how complex the burden of morbidity and mortality for minority mothers really is, and it focuses on social determinants. Starting on the left, you can see that race or ethnicity sets the tone for patient factors, community and neighborhood factors, provider factors, and system factors. We've not had a chance to touch on all of the bullet points listed under each category, but I hope that these are some of the things that have been in the back of your mind as we've been moving through the presentation. With all of these considerations in reality, in the light red, you see the health status consequences, which include hypertension, diabetes, obesity, depression, and of course, the likelihood of pregnancy complications. The purpose of the right-hand side is to emphasize the importance in all components of a woman's care team working together to prevent detrimental outcomes of severe maternal morbidity and mortality. I mentioned at the beginning that a maternal death is a culminating event after a series of failures across the life course. This diagram shows how a comprehensive care model must be used to address this health disparity. We've made it to the point where I hope to provide you with some hope. I know that much of this information can be very daunting and leave you wondering, well, what can be done about it? There are several intervention recommendations that have been developed based on what we know. We're going to discuss them from what women can do for themselves all the way up to what the United States can do for its women. On an individual level basis, one of the main challenges that has been revealed is that women are not being provided enough info about potential warning signs of complications related to pregnancy and the postpartum period. How can women advocate for themselves if they don't know enough to tell when something's wrong? Patient activation is a term that has been coined to encourage women to play active roles in their healthcare experiences. In order to be effective in doing so, it is critical that they are taught self-advocacy skills or being able to speak up and ask questions, increase their awareness or the ability to recognize a possible medical error, increase their health literacy about their bodies and health, and remain vigilant or focused on preventing harm. On the right here is a tool from a campaign that is often cited as a national example. It details for women potential concerns such as blood clots or shortness of breath, why it's important that they act on these signs, and where they should seek assistance. The interpersonal level is where social support comes into play. Culturally, many women are accompanied by friends or family members during the delivery process. Therefore, in addition to women playing active roles in their healthcare, families are also encouraged to serve as advocates for their loved one's safety and quality of care. Family-centered maternity care is a notion focused on advancing mutually beneficial relationships between women, their families, and their healthcare providers. Due to the strain of childbirth, many women are often unable to completely comprehend postpartum education provided to them. Here, family members or partners are encouraged to take the leadership role and ask questions to ensure that the information being reviewed is understood. Once home, the social support systems of women play a major role in achieving patient adherence to medical recommendations. Keeping mom safe and healthy is significantly more likely when she is surrounded by informed loved ones. The organizational level is likely where you consider first when addressing maternal morbidity and mortality. This is the level where providers and hospitals are targeted. I have highlighted 4 of the common areas of intervention for this group. standardization of medical care practices and health system-related quality improvement is the main focus. There are several examples of developed interventions to date, including the Making Obstetrics and Maternity Safer ACOG program, which was founded in 2010 to ensure safe birth, guidelines, screening tools, and counseling methods for pre-existing medical and social conditions, protocols and checklists for discharge procedures, the Are You Pregnant or Have You Been in the Last Year campaign, reminding all providers to always ask women regardless of the reason for a visit. There have also been clinical tools developed to improve timely assessment and treatment of complications. Examples of these include the Maternal Early Warning Trigger Tool and Maternal Early Warning Criteria. Next, we have maternal safety bundles, which are guides funded by HRSA and developed primarily by ACOG to assist clinicians and hospitals in addressing the major causes of severe maternal morbidity and mortality. A special example of one of those is on the top right. It provides guidance for how racial disparities can be addressed in a clinical context, including everyone on a care team from admin to physicians. Last but not least is provider training. The goal of clinical interventions with healthcare workers is to limit the occurrences of poor diagnoses and failed opportunities for treatment. The resources available to women depend on their physical and social environments, right? Particular social determinants of health considered to be risk factors for maternal mortality, for example, poverty, lack of education, poor nutritional status, and smoking, are more easily addressed at the community level as opposed to in the clinical setting. The safety bundles that we just discussed are often promoted by community health educators who are tasked with ensuring that the guidelines are actually implemented in hospitals. For minority women, comprehensive care programs and communities are well supported by favorable research. This requires collaboration from all specialty providers in women's healthcare. The program should be designed to account for preconception prevention, intrapartum disease management, and interconception care. Of particular importance is the significant role that non-medical support, such as doulas, can play in disrupting many of the negative associations between social determinants of health and maternal health risks that we've discussed. They are likely to improve outcomes, satisfaction, and quality of maternal care delivery. We've reached the top, the societal or policy level. Here's where we discuss laws and what that means for the pregnant women in our country and community. While all of the ideas that we just discussed sound promising, without funding, they're not likely to be implemented. The good news is that over the past few years, we've seen several bills introduced due to increased awareness and outrage over the number of deaths that could have been prevented. I have listed some here on the right. However, it was the Preventing Maternal Deaths Act that actually passed in 2018. The overall purpose of this bill was to strengthen, support, and expand maternal death prevention programs and data collection and reporting. Most recently, the Black Maternal Health Omnibus Act of 2020 has made headlines. This package of 9 bills seeks to invoke policy changes to improve maternal health outcomes on several fronts, including for veterans and the incarcerated, to advance research on social determinants, to emphasize diverse workforces in underserved communities, to make culturally competent mental and behavioral specialists more accessible, and to invest in maternity care technological innovation. I would encourage you all to read about the specifics of each bill and to stay in the know by tracking their progress. Now that we review what suggestions are recommended to work towards alleviating these maternal health challenges, we're going to end with what is actually being done. In the United States, the CDC is responsible for all population-based efforts surrounding maternal health. Here I have listed the 4 main initiatives dedicated to morbidity and mortality improvement. First is the Pregnancy Mortality Surveillance System, or PMSS. This entity is responsible for evaluating national data and identifying risk factors to release summative reports to the public on its findings. Next is the Enhancing Review and Surveillance to Eliminate Maternal Mortality, or the ERASE initiative. This program provides funding and support to the Maternal Mortality Review Committees in 25 participating states. Then we have Perinatal Quality Collaboratives. The goal of this initiative is to improve the quality of care for mothers and babies by establishing networks of leaders within and between states. Lastly, the Levels of Care Assessment Tool, which is the web-based design accessible to states for creating their own standardized care model. Luckily, Florida is one of the states with a sponsored Perinatal Quality Collaborative group. What I wanted to show is that here, clinical interventions have been implemented, researched, and reported on with respect to maternal morbidity and mortality. On the left are 2 past projects completed by the FPQC, addressing both hypertension during pregnancy and obstetric hemorrhage. The HIP initiative targeted both the provider system and patient education, collaborating with 32 hospitals throughout the state. Data summaries and developed toolkits are available on their website for the public. The OHI initiative was presented as more self-led instruction for hospital systems to use, provided resources and apply recommendations as needed. 3 years of webinars on the topic are also available on the website in an organized file folder for review. An ongoing project is the PROVIDE initiative, which is evidence-based and designed to reduce NTSB cesarean section. They are supporting and participating Palm Beach County hospitals. In terms of maternal mortality efforts, maternal mortality review committees are equivalent to randomized controlled trials in epidemiology. So what that means is they're the gold standard. These committees are comprised of representatives from a variety of backgrounds, including public health, obstetrics and gynecology, behavioral health, patient advocates, and even social workers. The difference between these reviews and typical US surveillance is in the access to medical and social records of deceased women. Each reported maternal death undergoes an in-depth review that takes into account contextual social determinants of health that may have led to the death. The goal of these reviews is to determine points for assessing preventability and sharing recommendations that can be implemented to promote intervention recommendations targeting multiple levels. Florida's PAMR was created in 1996, and to date, over 2,400 pregnancy-associated cases have been reviewed. The Florida PAMR uses their findings from investigating deaths to develop announcements, recommendations, and urgent reminders for OBGYN providers throughout the state. Here I have included 3 screenshots of some of the headers from past releases. And just this week, one regarding opioid use during pregnancy was distributed to providers in Palm Beach County. If you're interested in reading these, this content can be found on the Florida Department of Health website. You can see that in these releases, many of the topics we've discussed are accounted for, such as cardiomyopathy, hemorrhage, and the maternal early warning system. This indicates that our state is putting into action new findings as the information becomes available, and we are seeing the improvements as a result. That is all I have. Thank you so much for your time today. I have listed my email address and phone number here for anyone who might want to take that down. I have also compiled a quick resource guide of references and listed the link to my full bibliography on a file that we will share in the chat. Now we'll go ahead and open it up for questions. If for any reason you don't feel comfortable asking in this forum or we're unable to get to yours, please feel free to send me an email.
Thank you so much, Faythe. Faythe, I just wanted to share with you that someone messaged me privately during the presentation and said this is the best training webinar that she's been in since the beginning of COVID. So just some
I'm glad.
Yeah. So lots of good feedback and really important topic.